Good afternoon. So I'll be talking about the case of Chagas disease that was mentioned earlier this morning as an example of trying to innovate a bit in the field of access, not only with the use of the PRV benefit, but also on the way we've conceived the idea of scaling up treatment and diagnostic. So just as a quick reminder, we could be spending a lot of time on explaining a bit the mechanism, the disease, the profile, but I think here the main point is to talk about the disease burden and the fact that it's estimated around 6 million people infected, essentially Latin America. We tend to say it's a globalizing disease in a sense that due to migration flux, you do find a lot of cases in the US and in Europe. I think here, particularly in the, it's a very old disease with existing treatments. And the main point here, maybe as a takeaway for this slide, is the fact that we have estimated 1% of the people with Chagas disease who are actually being diagnosed or treated. So basically 99% are not treated, which is quite extraordinary as a case compared to many other neglected tropical disease. In the case of DNDi, we do drug development. We're a non-profit R&D collaborative model. And so we're essentially driven into science and making sure we do innovate in terms of treatments, essentially. So in the short term, we have our R&D strategy focuses on, in the case of Chagas, in optimizing existing treatments, so essentially around the benzonidazole that was mentioned earlier, and then also preparing, developing a pipeline with promising compounds. And attached to the R&D strategy, we have an access arm, which is important, and I think in the short term, in a way, what I'm trying to talk today is the short-term access strategies, try to demonstrate the feasibility of a new methodology to scale up access to diagnostic and treatment. In the long term, we aim and hope to be able to reproduce, to replicate, to tailor as well to needs in other countries, this initial pilot projects for access to existing treatment. So the DNDi Chagas Access Initiative has really as a name, essentially aspect that we would look in many other diseases, to some extent here focusing on specific activities of the scaling up of the diagnosis, scaling up the number of people having access to the treatment with the existing drugs. But I think what we've tried to include in this particular model is a sort of more collaborative, more consultative approach in the way we've developed our kind of regional strategy. There are aspects of registration of the drug, which are in the short term essential, at least in those countries where the drug has not been approved yet. There is a lot of access-related research. I'll show you a bit more later. And with that comes a sort of capacity strengthening in making sure that we build something that would be eventually sustainable at the level of the public health systems in the endemic countries. We work a lot with different partners. So I'll show you a better list of, but I wanted to highlight here the fact of trying to promote a sort of advocacy groups, patient associations of Chagas who are themselves going to be supporting the development of this effort. Another aspect of the way we could be looking into the efforts on access to Chagas in this initiative is a slightly more comprehensive way to identify needs and particularly barriers and ways to look into what solutions to overcome the barriers. So there are the classical, let's say, clinical and structural aspects that are looked into, but we've tried to put as well in the analysis here a more systemic approach, which would be also betting on the fact that we would like the system to be embedded in primary healthcare and basically breaking a bit the hyper-medicalization around access to diagnosis and treatment that we can see in many parts of Latin America. That comes with a lot of course, efforts in the field of training, education, of health professionals, but also in a sense of marketing the disease. And that touches me the last dimension, which we put under a kind of psychosocial dimension, which is a bit unusual to look at, but looking into the dimensions of how patient groups can actually themselves support the effort, as I was saying earlier. Looking into aspect of mental health, for example, when it comes to receiving not only a diagnostic but a treatment, because we know it's a disease as many other neglected tropical diseases with a huge stigma. So we've decided to take on board as well a sort of psychosocial dimension in the analysis of the problems. It's very much, again, based on partnering with a vast array of stakeholders. Earlier was mentioned around the PRV and the use of the benefit of the PRV, clearly a collaboration with Fundación Mundo Sano in Argentina, but more in the implementing aspect of what we are doing in some parts of Latin America. It's really engaging a vast array of public and private institutions from ministries of health at the central level, but at the local level, municipalities, experts from different fields of science and social science as well. The WHO, of course, is on board, and as well as the PAHO. And we've created an access consultative group, which is also pro bono experts in their areas of expertise. So we have health economists, we have anthropologists, we have people specialists of the disease who are accompanying the pilot projects. I'm giving here quickly an example of Colombia, which was the first pilot project we've initiated. It was why Colombia? Essentially because there was a story of success in the field of onco, and we thought that there was a timing, a momentum for ISNTDs, and surfing on the wave of success is not a bad thing. Second point, there was a sort of geopolitical context with the signature of the peace treaty with the FARC that allowed a vision into certain areas of Colombia where there are actually high endemicity, to try to reconstruct the country. So we tried to put Chagas on the agenda of the reconstruction, as there was a willingness at the highest level to try to engage. So there was a favorable context to start on Colombia. We started in 2014, 2015 with the first consultation, having again the very vast array of people from Ministry of Health, universities in Colombia, engaging in a problem of a diagnosis of situation, looking in different dimensions of the problems. It was a very long and comprehensive analysis, and I want to focus on that aspect of the methodology of what we have developed as an experience. We'd call a kind of a 4D approach compared to the 4A approach, sort of looking into an in-depth diagnosis of the situation, where the problems lies, and trying to identify potential solutions, and around that building consensus with the stakeholders. The whole idea here is really a non-substitution approach. So as we went about analyzing the problems and analyzing potential solutions, we designed the project. So it was a sort of, as you use in social science, a sort of research action approach, if you want. So that led us to working into 4 municipalities, as you see here on the map, as a pilot experience under a strong monitoring by the Ministry of Health to identify the route for diagnosis and the route for treatment. I give here just a slide, quick one, on a particular slide. I think is illustrative of the before and after. By the moment, to put some attention, particularly around diagnosis in this particular community of Tamara. Before the project started, patients who had been tested were around 10, 11 people a year. And after the experience was put in place, we raised substantially the number of people who were actually tested. But more importantly is the figure on the third line, the mean days between the moment the blood is the test on patient is done. It used to be about something like almost 2 years to get the result of the blood test to know whether it was positive. And with this new route on how to diagnose, we were able to lower that to 2 weeks. And that is essential, of course, because it's very obvious. I won't even need to explain the consequences of such a long time of waiting for a very neglected disease. So lessons learned quickly, and I hope we'll have questions later, but I think it's really about supporting local initiatives at very grassroots. So we were very adamant that it had to be embedded at the level of municipalities in the case of Colombia. There was a huge buy-in at governmental level. That was also a nice coincidence, the fact that the Minister of Health himself took the initiative as a personal effort, and that helped a lot, of course, opening doors and facilitating the sort of ownership at the different levels of the Ministry of Health. We engaged a vast array of stakeholders, as I said, clearly trying not to impose from above, but trying to be as horizontal as possible. Starting very small, that was also a takeaway, I think, from the experience in Colombia. Creating pilots, building evidence, publishing the evidence, building momentum as we went through the experience was very important. And it was only in this way that we're able to move in Colombia a little bit as compared to 100 years of neglect on this disease, on access to treatment at least. I think the project, as we initiated in 2015 in Colombia, in 2016 starting to work with some centers of excellence in the US. As I was saying earlier, the disease is globalizing. There's estimated 300,000 cases in the US with no access in the same way to diagnosis and treatment. So there were a lot of things still ongoing. The Brazilian government has opened a real dialogue on changing the approach to treatment very recently, so we are collaborating a lot. And as we speak next week, we'll be launching a similar exercise in Guatemala. So those are the 4 experiences, and I hope we'll see a change in this 1% next time we meet. So thank you very much.